All right, so I'm just going to do a little recap of today. First, I'm going to talk about fluid imbalances such as fluid volume deficit and fluid volume excess. So remember, deficit occurs when you have extracellular fluid loss that's greater than your fluid intake. You can also have an osmolality issue, but that's more going to occur with sodium imbalances, so we don't really talk about it with fluid volume deficit. Your risk factors can be increased caffeine or alcohol intake because those are going to dehydrate you. Strenuous exercise because you're going to lose a lot of fluid if you strenuously exercise. Dry climates. Causes of fluid volume deficit can be hemorrhage loss, diabetes insipidus because you are urinating a large volume. Burns can cause fluid volume deficit, diuretic abuse, and GI loss, such as vomiting or diarrhea. Some signs and symptoms. Our patients are going to exhibit oliguria, so they're not going to have a lot of urine because what urine they have, they're going to hold on to. They also are going to have concentrated urine because when they do urinate, they are holding on to what they have, so when they urinate, it's not a lot. They are going to have a decreased level of consciousness. They could have thirst. They could have dry skin. Their skin turgor is going to be poor. They're going to have dry mucous membranes. They're going to have a low blood pressure, and it's going to get worse with movement. Their pulse is going to be tachycardic as well as weak, so it's weak and thready. And their neck veins are going to be flat. Their labs, what we're going to notice is an increased hematocrit and an increased hemoglobin. And please don't forget, labs on Blackboard are called ATI labs. You need to know those labs. You're going to have an increased serum and urine osmolality, an increased BUN, and an increased specific gravity of your urine. The management is going to be PO or IV fluids, and that's going to be per the doctor. It can be hypotonic or isotonic, it just depends. Eyes, nose, monitor for skin breakdown, provide oral care. You're going to fully assess your patient. You want to ensure that you do daily weights, and you're going to monitor your labs. So fluid volume excess is also known as hypervolemia. So fluid volume deficit is hypovolemia. Fluid volume excess is hyper. Basically, the patient is overloaded. They have too much fluid in their body, in their intravascular space. This is not third spacing. This is fluid volume excess in the intravascular space. Third spacing is when the fluid goes into the interstitial space and can't be utilized. So some contributing factors, things like heart failure, renal failure, and cirrhosis. These can all contribute and make fluid volume excess worse or occur. Some signs and symptoms. You're going to have level of consciousness changes. You're going to have a headache. You could have seizures. You're going to be tachycardic, but this time it's going to be abounding tachycardia. Your blood pressure is going to be increased because of all your volume that you're trying to circulate. Your JVD, your neck veins are going to be increased. The patient, if it's severe fluid volume excess, they could have pitting edema, and as well as shortness of breath and crackles. The labs that you will note are a decreased hematocrit, decreased hemoglobin, decreased urine and serum osmolality, decreased urine sodium and specific gravity, and a decreased BUN. You might also have dilutional hyponatremia, which would be a decreased sodium, but not always. The management of this, you are going to administer diuretics per the doctor's order. So generally they'll use thiazide diuretics for a mild fluid volume excess, and for moderate they're going to use loop, moderate to severe. They are going to want to do some nutrition things, so maybe restrict their fluid, decrease their salt intake, daily weights, eyes and nose, and then the nurse needs to make sure that he or she is doing their assessments. However, every 4 hours, every 8 hours, however often it needs to be done. sometimes every hour, just depending on where you are. And reposition as needed to help prevent tissue breakdown and monitor labs. Then we're going to talk about hyponatremia. So hyponatremia, we have two different kinds. We have true and we have delusional. Please pay attention to what is in red. Like, it's nice to know everything that is on here, but it's kind of difficult sometimes to know everything. So pay attention to what's in red because you definitely need to know those things. So for true hyponatremia, we have vomiting, suctioning, and diarrhea as the cause. So basically GI losses. Sodium level is going to be less than 136. The patient will have orthostatic hypotension and level of consciousness changes. The way we manage this hyponatremia, well, if it is significant, like they are on the verge of having a seizure or they came in having a seizure, they will administer hypertonic IV solutions. However, it is only done for severe hyponatremia and it's done in an ICU setting. So isotonic fluids are much more reasonable for somebody that is hyponatremic because your isotonic fluids are not going to decrease your sodium. You do not want to give somebody that's hyponatremic hypotonic fluids, however, because that will decrease their sodium, and that is not what we want. You are also wanting to place these patients on seizure precautions, especially if their hyponatremia is significant, and then eyes and nose. There are two kinds of hyponatremia. I didn't go into it in class, but you can have an acute hyponatremia and a chronic hyponatremia. People who chronically have low sodium are less likely to have a seizure. However, with low sodium, you do not want to raise the sodium too quickly because then you can have a demyelinating event that occurs. And it's caused by basically you're pulling all that fluid and it goes into your brain. So you're having like a cerebral edema. So always be cautious when you're correcting sodium because you don't want to correct it too fast. You then have dilutional hyponatremia. And dilutional hyponatremia, the things that you need to remember for causes is that dilutional hyponatremia can be caused by water intoxication, like somebody drinking way too much water, which is rare because most of us don't drink enough, heart failure, renal failure, and cirrhosis. Confusion, weight gain, and edema are your big symptoms, and you again want to monitor their eyes and nose, but you also need to restrict their fluid intake. For hypernatremia, it causes excessive sodium intake, obviously. Cushing's and renal failure and hyperaldosteronism can also contribute to it, but the thing to really remember is excess sodium. Your symptoms, your patient is going to be thirsty, they're going to have a dry tongue, dry mucous membranes, flushed skin, they're going to hold on to their urine, they may have a low-grade fever. They also could be confused or restless. Remember the acronym fried salt, which is right there for you. And then you want to put this patient on, you're going to do eyes, nose, and you're going to put them on seizure precautions. Now potassium, the range for potassium is 3.5 to 5. So, hypokalemia, GI loss, medications, certain medicines like loop diuretics, corticosteroids, insulin. The signs and symptoms of hypokalemia. We have fatigue, muscle weakness, and paresthesia. You can have cardiac arrest if your hypokalemia is significantly low. EKG changes. You're going to have a U wave. You're going to have a weak respiratory muscle. So you can use the acronym SICK-WALT, which is there to help you remember your signs and symptoms. So the treatment, like emergent treatment, oh wait, this is hypo. So treatment, if it's significantly hypokalemic, is going to be IV potassium. Please, 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 please remember that you never give IV potassium IV push. You also don't want to give IV potassium sub-Q or IM. Don't want to give it faster than 20 milliequivalents per hour, and you're going to monitor for any complications at the IV site because IV potassium burns, and patients complain of it. You want to make sure you encourage an intake of high potassium foods such as fish, fruit, citrus fruits, avocado. Just make that red because you need to know that. I wonder why. And then you want to make sure that you put them on the cardiac monitor if their potassium is less than 2.8. So for hyperkalemia, things that cause an elevated potassium, we have kidney insufficiency, oliguria. We also have some medicines like ACE inhibitors, and we'll talk more about that when we get to cardiac meds, because those are cardiac meds. So anything that's above 5.0 is considered hyperkalemia. It is significant, like it's like an issue when it's 5.5, 5.6, 6. Like doctors start correcting it pretty quickly when it starts getting 5.5. They'll want to correct it. So some issues, cardiac issues and arrhythmias. You're going to have tall tinted T waves. Remember the acronym MURDER. Remember that potassium affects muscles, so it's not just the heart, but it's also going to affect your respiratory muscle and other muscles in the body. Emergent treatment, IV calcium gluconate, IV regular insulin, and D50. The insulin is to help push the potassium back into where it goes, and the D50 is so the patient doesn't become hypoglycemic. In severe cases, they are going to have dialysis. Now for calcium. So hypocalcemia, you have certain causes like renal failure, malabsorption syndromes. The thing to remember, though, are your signs and symptoms. Remember the CATS acronym: convulsions, arrhythmias, tetany, and stridor. So stridor, going to have a positive Chvostek and a positive trousseau. Remember, Chvostek is cheek, trousseau is your arm. You're going to have tingling and numbness when you have calcium that's low. The big thing with it is you want to place them on seizure precautions and a cardiac monitor if the calcium is really low. With hypercalcemia, we have, again, excessive intake, metastatic bone cancer, or the patient's immobile, which is a rare way for somebody to get hypercalcemia, but it does happen. The big thing to remember with hypercalcemia is that the patient will get weak. They can have some EKG changes, but that's with significant increase. You want to make sure you move the patient that is immobile carefully so you don't get a fracture, because the calcium is going to leave the bone and go into the bloodstream and make it hypercalcemic. You need to remember the saying groans, moans, bones, stones, and overtones to help you remember your signs and symptoms. So groans, constipation. You're very constipated with hypercalcemia. Going to have joint pain, which is your moans. Your bones are not going to have calcium in them because it's going to be in your blood. You're going to have kidney stones, and you could have some psychiatric confusion, which is what the overtones are. Magnesium. Okay, I have hypermagnesium on here, but we're not going to worry about hyper. We're only going to worry about hypo because that is what the book talks about. So hypomagnesemia. Basically anything that causes a GI loss, Crohn's disease, DKA, acute pancreatitis, and alcoholism. Notice it's in red. So ATI says that the number is 1.3 to 2.1. So I guess I should change this to 1.3 to 2.1 because that's what ATI says, and we want to be what ATI says. 1.3 to 2.1. All right. So the big thing with hypomagnesemia is torsades, which is a cardiac dysrhythmia that can lead to lethal consequences, and you'll learn about it if you choose to do ACLS. Another thing with hypomagnesemia is you're going to have a positive Chvostek and Trousseau's. When you have low mag, they're going to give IV mag for it. If it's not too terribly low, they might do PO mag, but expect IV mag. All right, so we talked about that. There's another Word document that I've created that talks a little bit about electrolytes. So it has some things in it that I didn't really talk about, but you might need to know them, especially for NCLEX, like calcium helps coagulation. But it just is to help you guys. So if I didn't talk about it, don't get too terribly strung out about the fact that it wasn't talked about. But if it's in red, I would know it. And then we're going to talk about comparing fluids. Okay, so remember your isotonic fluids, you have the normal shift. Your hypertonic fluid, your cell is going to shrink, and your hypotonic fluid, your cell is going to swell. So, again, let's pay attention to the red. I didn't talk about it in class, but D5W is one of those that outside the body it's isotonic, and inside the body it's hypotonic. All right, so isotonic fluids, basically your normal saline and your lactated ringers. They give LR a lot in the OR, and on the floor we give normal saline a lot. For hypotonic fluids, remember it makes the cell swell, so think hippo. You don't want to give to a patient that has ICP or is at risk for ICP due to the fluid shifting into the third space. So signs of increased intracranial pressure are level of consciousness changes, pupillary changes, motor sensory deficits. Third spacing, ascites, burns, trauma, peritonitis. And the big one, the isotonic fluid that I always remember is half normal saline. With hypertonic fluids, think of your incredible shrinking cell. They're hyperactive, and when you're hyperactive, you're running around and you're skinny. So it's only administered in an ICU setting, and it's only administered through a central vein. So I doubt anybody, like maybe 1% of the student population, will be administering a hypertonic solution at some time. Then we have certain delivery methods. We have the peripheral line, which is just the regular IV. We have an extended length catheter, which is an ELC, and it can stay in longer, but a special nurse has to put it in. Then we have central lines. PICC is a central line. It requires a consent. Through the PICC, we can have total parenteral nutrition, a large volume of fluid, and anything that is vessel irritating. Those are things that would be required, like that's why you would want to PICC, because they don't have anywhere to stick. They're getting TPN, they're getting a large volume of fluid, they're getting vessel irritating drugs, or they're going to be on long-term antibiotic therapy. So complications, we have infiltration, which I talked about. Remember, it's swelling at the site and coolness. Phlebitis, pain and redness. And the way we prevent those things is we want to rotate our IV sites per policy, and we want to get large veins. So extravasation is basically infiltration of medicine that is considered a vesicant. So if you remember those pretty pictures I showed during class, we have burning or pain at the site, and then we can have blistering and necrosis. So anytime a patient is complaining of pain at the IV site, it needs to be assessed. Now, certain medicines cause pain, like potassium. Potassium can be a vesicant if it infiltrates. So if potassium burns, we need to assess our site and make sure that it's not infiltrated, and decrease our rate after we assess it and make sure that there's not a problem with the IV. If there is a problem with the IV, the first thing you want to do is to stop the infusion. That's the very first thing that you do, stop the infusion, because you're just continually putting it into their vein if you don't stop the infusion. After you stop the infusion, you're going to notify the doctor and perform any interventions that need to be performed. The patient could develop an air embolism, and this is very rare. And when you're doing an IV, when you're putting an IV in, you always want to use sterile technique. Always, always use a regulation device, preferably a pump. This is the most accurate. If you're in a trauma situation and you can't use a pump, you have to bolus, that's okay. But if you have the time, get a pump. That is the most accurate. And then always remember, with your older, or with any population, when it comes to IVs, you want to always listen. Your older population they're going to have like some experience with IV therapy, so they're going to know where the best place for a vein is, probably. So you should listen to them. If your patient is telling you that their IV hurts and you assess it and it looks fine, like you're not giving potassium, you're giving saline, and their IV hurts, you assess it, you touch it at the hub, and it's not hurting there, but you touch it above, and it's hurt. Because some people are going to say that their IV hurts, and you reposition where the hub is on the skin, and it stops hurting. But you do that, and it still hurts. You should take that IV out. You should find another place to put an IV. Because if they're telling you it hurts, then that's the first clue that something is going to happen. So trying to prevent phlebitis or infiltration is always better. And then teach your population of patients that are oriented and understand to let you know if their IV starts hurting. You can't teach everybody, because not a lot of people, but there are some, issues with level of consciousness, mental status changes, and those people aren't going to understand, so you can't teach them. But if your patient is alert and oriented, please teach them. All right. So, hopefully you have enjoyed this and have watched it. And, yeah, I'm sure you'll do well next week. I have faith in you. All right. I will see you later.